A very good evening to all of you. This is Dr. Vijendra. Khalil sir, can you hear me?
Yes, Dr. Vijendra.
Yeah. Very good evening, everyone, and welcome to this online IAMM-TAPC webinar. Today, it gives me a privilege to welcome Dr. Mohammad Khalil sir, who is one of our favorite teachers in microbiology for a long time. He is currently the Vice Principal Academics, Professor and Head of Department at Mahavir Institute of Medical Sciences. He is also the consultant at NICE Hospital. He is the Chief Coordinator of the Medical Education Cell, Head in the Division of Microbiology Lab. He has been the ex-secretary of the Indian Association of Medical Microbiology State Chapter, from whom I've learned a lot. He has done his MBBS and MD from Gandhi Medical College. He's also a master in hospital management from Osmania University and is a fellow of the advanced course in medical education. He's a recipient of various awards and honors, has more than 31 publications to his name, about 2 books, and many chapters to his credit. With regard to teaching, he is the resource faculty for many national and international students, both online and offline, caters to undergraduates, postgraduates, students who are aiming for NEET, AIMS, JIPMA, PGI, USMLE, and FMGE. He's a life member of the National Teachers Training Center of the Association of Medical Educationists, has undergone various training and certificate courses. So, good evening, and then it's an honor to have you, sir. And it's always a pleasure to listen to you. Over to you, sir, for this topic.
Thank you, Thank you, Dr. Vijendra, for that honors. It's a privilege, and I'm overwhelmed today to be a part of the PG webinar series for our own state chapter, IAMM-TAPC. And I wholeheartedly thanks and my gratitude towards the association, also executive members, for having given me this opportunity. Took some time, but Vijendra has been calling, but finally I knocked the button. I said I would agree to give a talk. And the choice of the topic from sepsis to survival, getting empirical antibiotic therapy right in the ICUs would be the apt for the post-graduation who are appearing for their examination, and also day in, day out when we have clinical grand rounds with the clinician. I thought this would be right chapter to be talked about. So the objectives of my session would be talking about the different infections in ICU, the pathogen parade, talking more on the back to basics because our fundamentals have to be strong, because we have to know where the bug acts, uh, and also the relation to the drugs, antibiotics and mechanism of action, and a small note on antimicrobial drug resistance, because this is a very vast topic. I would not go into the details, but again, the drug and bugs, the PK/PD of the drugs and different variations, which are very challenging us to take a call. And finally, I will conclude with some remarks. So having said that, my talk is to provide mostly on evidence-based recommendations for antibiotic usage as per the recommendations from UCAS, CLSI guidelines, and European Society Intensive Care Medicine. Uh, Also to optimize patients' outcome and combat antibiotic resistance. Early initiation of antibiotics is very, very crucial, as everybody knows that, and most of the clinicians who have a good rapport with the clinical microbiologists are totally dependent, and we have that mutual respect, and that we have to earn it. And it's taking a call within first hour of the ICU admission. And as I said, empirical therapy should cover common pathogens with combination therapy recommended for especially the severe critically ill cases. And I hope I would also justify my talk in addressing the emphasis, the need for tailored antibiotic regimens based on local microbiological flora and data and resistant pattern in our combined state especially. Patients admitted in ICUs basically are already critically ill and vulnerable, making them more susceptible to these infections. As you can see, it's a hub. Basically, the ICU is so crowded, and meticulous care has to be taken, which again increases, added to that, the length of hospital stay, adding to that morbidity and mortality. And mostly these infections are associated with invasive medical devices on the patient, might be a COTI, CLAPSI, or ventilator associated stuff. And you have a lot of central venous catheters on this patient. Then the prolonged ICU stay itself would be another risk factor. And added to that, we also have different CNS manifestations like meningitis, encephalitis, and also various intra-abdominal infections. When a patient is admitted with pneumonia, pelvic inflammatory disease, cellulitis. And coming to the risk factors, as I said, use of invasive devices left and right on the patient with prolonged ICU stay, which add on to the morbidity and mortality, with compromised immune system already added to that pre-existing conditions, like it could be a trauma or the immunosuppression that weakens the defenses, and different underlying conditions like diabetes or chronic heart disease, chronic obstructive pulmonary disease increase their vulnerability. And moreover, as you can see, this patient have already been exposed in the community, or going through various like window shopping from hospital to also door to door, and previous and prolonged course of antibiotics can contribute again to the development of resistance organism. So these are all the risk factors which can contribute definitely to a very challenging situation where to take a call empirically, start the treatment in ICUs. Yeah, this is the basic chart which I thought again to let the PGs focus on what exactly is the backbone of why these antibiotics do not act on the gram-negative bacteria. As you can see, the major difference is the virulence factors in gram-positive is lipoteichoic acid and teichoic acid. And the major virulence factor is the outer membrane and lipopolysaccharide, which together are known as the lipid A or the endotoxin. Now, the additional outer membrane that is present here would definitely add on a factor to the gram-negative bacteria, so that the antibiotics would not be much efficient compared to gram-positive. Hence, the reason gram-negative sepsis is more common and more dangerous or fatal compared to gram-positive bacteria. Yeah, overview of the pathogen parade. As you can see, we have different gram-positive bacteria like Staphylococcus, Pneumococcus, other streptococcus, which could be your pyogenes, which could be your viridans and atelectasia in case of neonatal septicemia, or endocarditis might be viridans. And you also have the deadly post-op UTI and gastrointestinal infections, enterococci, which is a normal commensal and forms 80% of the normal flora. But post-op, it could be a very multi-drug resistant organism. Then you have Listeria monocytogenes, which can again cause meningitis in your immunocompromised patients, and also in your neonates. Then you have also Bacillus anthracis, which is not much common, but it can infest your cutaneous, pulmonary, and abdominal manifestation. Coming to your gram-negative bacteria, एक second, got stuck over. Yeah, we have Enterobacteriaceae again, which includes your E. coli, Klebsiella, Pseudomonas, Proteus, your Neisseria, H. influenza again, which is a cause of pediatric meningitis, your Campylobacter jejuni, Helicobacter pylori, Acinetobacter, which is again your MDR bug. Coming to the atypical bacteria, we have Legionella, Chlamydia, Mycoplasma, Brucella, and Rickettsia. And the last junk, which forms the part of the ICU pathogens, are your anaerobes, the major component being occupied by the Clostridia species, yeah, bacteroids. Then you have spirochetes, uncommon, rare. Then you have your Mycobacteria tuberculosis, and also in immunocompromised patients whose CD4 count is less than 50, and especially HIV patients, you have the Mycobacterium avium intracellular complex. Now, this is what I was talking about, the basics part. As you can see, this is one of the very important picture which depicts a lot of information. Let's start with the antibiotics that acts on the cell wall synthesis, especially the beta-lactam antibiotics. We have penicillin, cephalosporins, carbapenems, the monobactams, which acts on the cell wall. And you also have non-beta-lactam uh, bug drugs, that is vancomycin and bacitracin. That's the reason we have separated this from the beta-lactam, because they are non-beta-lactam antibiotics that acts on the cell wall, and they are bactericidal in action. Then we have antibiotics that act on the cell membrane. We have polymyxin B and colistin. Moving to the antibiotics that acts on the protein synthesis, that is the 30S ribosomal unit and the 50S ribosomal unit. We have aminoglycosides, the tetracycline groups, which acts on the 30S. These again bactericidal. Then you have 50S, your macrolides, clindamycin, linezolid, chloramphenicol, and the streptogramins. Now, there's a mnemonic that how you can remember the bacteria, that the drugs that acts on the 30S and 50S ribosomal unit. There's a saying that, if you invest during your young age, like 30, 40, and you can reap that in doubles or triples when you become 50 or 60, like you invest in land or invest in gold. So the mnemonic here goes by saying, buy at 30. You buy something at 30 years of age. B at 80 is the mnemonic. A is aminoglycosis, T tetracycline, and sell at 50 years. C stands for two C's, your clindamycin and clonophenol. E for erythromycin, which is a part of macrolide other than your telithromycin and clarithromycin. So two C's, one E, CCE, L is linezolid, then CCELS, cells. S is streptogramin. You buy at 30 and sell at 50, definitely there would be a profit in your return on investment. Drugs that act on the DNA and your folate synthesis and your rifampicin, your RNA polymerase, you have rifampicin, the DNA gyrase, you have quinolones, then that is the first generation, second, third generation of fluoroquinolones. Then you have the groups of rifampicin that act on the RNA polymerase. Then you have drugs like clotrimazole, or which is a combination of sulfonamides and trimethoprim that acts on folate synthesis. Specifically, if you're talking about sulfonamide, they inhibit the enzyme that helps in transformation of para-amine benzoic acid to dihydrofolate and dihydrofolate to tetrahydrofolate that is inhibited by trimethoprim. There's one more drug which we missed it over here, that is metronidazole, that again acts on your topoisomerases enzymes and inhibit the nucleic acid synthesis. There's another mnemonic for remembering the drugs that acts on the nucleic acid synthesis in general. It is MRF, that is metronidazole, your rifampicin, and F is for fluoroquinolone, especially those on the nucleic acid synthesis and especially the enzymes topoisomerases 1 and 2, RNA polymerase, and DNA gyrase. So there are two mnemonics that way you can remember your drugs that acts at your different components of the cell wall. Having said that, let's move to the next slide. Yeah, antimicrobial resistant. Basically, I'm just going to give the definition. There are two types in broad view: intrinsic drug resistant and acquired. Intrinsic is basically the innate ability of a bacteria to develop resistance due to its inherent structural or functional characteristics. Like it's by intrinsically it only is resistance. It has not acquired and all. So definitely by you don't have to give these drugs when you come to know this drug is intrinsically resistant either in your OP or IP or your patient admit in ICU. Whereas acquired drug resistance is it has acquired through different mechanisms. It could be your transformation, transduction, conjugation, and uh, bacteria that are ordinarily susceptible develop resistance by acquiring genes coding through plasmids. And this is another reason for developing acquired resistance is because of the overuse and misuse of antimicrobial agents. Yeah, now let's concentrate on the action of the drugs. Let's have this panorama of these drugs. I have these emojis which says is doubtful. The one with the thoughtful I have depicted is that the action would be doubtful. It might act or might not act or might not act efficiently. Whereas this emoji indicates that it doesn't act. There's no role of these antibiotics. And there's another smiley emoji which says, or a thumbs up emoji which says it definitely acts. So let's talk about the antimicrobial activity of natural penicillin, that is penicillin G or V, which was initially a very good drug, wonderful drug that was given. But as of now, it's very unfortunate that these drugs, that is natural penicillin, does not play any role as such for any gram positive or any gram negative and atypical bacteria. And it could be started to empirical start. You can start with especially these anaerobic bacteria and except Clostridium difficile, which again this drug is associated with antibiotic oscillaria, this group of drugs, and also can be doubtfully or thoughtfully chosen for actinomyces israeli. Otherwise, this is not the drug of choice for any kind of gram positive, gram negative as of now, as of today. But again, penicillin again is another choice which can be empirically started for sore throat infections. They are allergic, then you can shift out for macrolides, and also your another drug is for STD infections. When again a test dose should be given, then it should be started on your maintenance loading dose and maintenance dose. So this is how the penicillin as of today, unfortunately, the picture is off. Moving to anti-staphylococcal penicillin. Now I'm going generation by generation to the most advanced drug. Coming to the anti-staphylococcal penicillin, you have nafcillin, oxacillin, dicloxacillin. Now, again, very doubtful role in all gram positive bacteria where there's no role at all for any gram-negative anaerobes atypical, please do not start empirically anti-staphylococcal penicillin unless and otherwise you find a gram-positive, especially Staphylococcus aureus or cons, and especially epidermidis. You can start it empirically only if it is MSSA, methylene sensitive staph aureus. Otherwise, anti-staphylococcal penicillin will not do any role in gram-negative atypical or your anaerobes. Yeah, coming to the antimicrobial activity, then what happened? Advance occurred. People started finding there's no role of penicillin then you have antistaphylococcal. Then they started with aminopenicillin group of drugs, which has a simple plain ampicillin and amoxicillin. Yes, these are the gram positive, these are the gram negative, these are the anaerobes which you find in again in your ICUs in different infections, which I have given a plethora of infections, like it could be pneumonia, it could be intra-abdominal infections, it could be meningitis, it could be device infections. So these are the different bugs. But yes, this is a doubtful antibiotic to be chosen, especially in antibiotics in ICUs. So what is left out is a combination of this beta-lactam plus beta-lactam inhibitors drug. Antimicrobial of aminopenicillin with beta-lactam inhibitor would be the right choice empirically to start in ICU. Like the beta-lactam inhibitors could be a clavulanic acid or sulbactam or tazobactam or avibactam. So the combo would be go like ampi with sulbactam or amaxiclav. Definitely they would be a good choice for gram positive, gram negative and anaerobes. Yes, it's the right choice. And the role of aminopenicillins is not the good choice as empirical drugs. In gram-negative, again, the aminopenicillin beta-lactamase is doubtful, but anaerobes, yes, you can go. These drugs, especially aminopenicillin plus beta-lactamase, that is ampi plus sulbactam or amexiclav, they can act against aerobic and also anaerobic drugs. You don't have to specifically depend on anti-anaerobic drugs like metronidazole. If you are started empirically with these drugs, they do take care of the gram-positive and also the anaerobic drugs. But the role of aminopenicillin with beta-lactamase is still doubtful, because we are talking about gram-negative sepsis in ICU. Following my slides, the next slide, I think we have the answer for what drugs should be taken for gram-negative bacteria. Moving ahead, yeah, let's see the antimicrobial activity of extended spectrum penicillin, that is piperacillin or ticarcillin. Same bugs, different ICU conditions. As you can see, not a good choice. But when you combine extended penicillin with beta-lactamase inhibitor combination, like cephalosporin sulbactam, ceftazidime avibactam, or piperacillin tazobactam, or minoperum vaborobactam, then yes, it's a very good choice. It will cover all your gram positive, it will cover your gram negative, and take care also of your anaerobes. Yeah, let's talk about next cell wall inhibiting agents. We have finished the first group, that is the penicillins and the aminopenicillins and the beta-lactamase combinations and all. Let's the group of drugs in cell wall inhibiting agents are the cephalosporins. Now the gram negative, as you can see from generation to generation, we have fifth generation. The gram negative activity increases with each generation except fifth generation. The gram negative activity except the fifth generation, because fifth generation is a separate group of drugs which acts against gram positive bacteria, which I'm going to disclose it in a few seconds from here. So in first generation, we have cefazolin and cefadroxil. Again, a doubtful choice empirically in ICU if the infection is with staphylococcus and streptococcus, but not for MRSA and MRSA. Staphylococcus epidermidis. Again, second generation cephalosporins. There's one term that has been used most commonly, cefamycin. Most of the postgraduates might, I don't know, they are confused, like what exactly when we're talking about cephalosporins, where is that word, the cefamycins are? Cefamycins is a term used for especially two drugs in your second generation. One is cefofitan and second is cefoxitin. Now let's talk about this. They are more potent against gram-negative bugs, and cefamycin especially, they have moderate anaerobic activity. That is cefofitan and cefoxitin. To start with, you can start, because if you are suspecting a road traffic accident or some anaerobic activity or cellulitis, but you have more good antibiotics or which can also take care of the your anaerobic activity, other including your gram positive, which would be your next slide. Third generation cephalosporins, you have cefotoxim, ceftazidime, ceftriaxone, cefoperazone, and these drugs would play a very important role in gram-negative because they have a very enhanced activity. But the another double-edged sword here, you have resistant, very common developing at the same time. Hence the reason you should use it in combination with IAMM-C. Yeah, then you have fourth generation cephalosporin, that is cefepime. There's only one drug and it has very good activity, enhanced activity against Pseudomonas aeruginosa, cefepime. Also, you have here in the third generation, ceftizidime, very active against Pseudomonas aeruginosa. And ceftriaxone also has long half-life. The advantage of ceftriaxone being very common drug. I mean, the favorite drug in third generation cephalosporins compared to among is it is a very good half-life, a good long half-life. And Pseudomonas aeruginosa, ceftazidime would be the drug of choice, especially drugs not acting. Then you can go for ceftazidime, sulbactam, or any combination with beta-lactam with beta-lactam inhibitors for Pseudomonas. Again, if that's not the choice, again, doctors would morely in ICU prefer cefepime because it's a very good enhanced activity against Pseudomonas aeruginosa and without compromising gram-positive cocci. So it will cover very nicely your gram-negative, especially Pseudomonas aeruginosa. Coming to your fifth generation, you have ceftaroline and ceftobiprole. Now, the specialty of these drugs, it not only covers a gram-negative, but also more active and much active against MRSA and your MRSA, that is Staphylococcus aureus, and methicillin-resistant Staphylococcus epidermis. Yeah, let's move out to the next third group of drugs in cell wall inhibiting agents, that is the carbapenems. They are very quite small, but they have charge characteristics which allows them to penetrate the gram-negative box. Now, this is like the physiological physio-bio conditions of the biophysics that you have to understand that some molecules are large and small, the charging and all. When you get into the details of PK/PD of this drug, then it will be easy to understand. And yeah, Enterococcus faecium and MRSA are intrinsically resistant. Now, this is some golden points you have to catch. You don't have carbapenems as the drug of choice if it is Enterococcus faecium and MRSA because they are intrinsically resistant. But yes, very good choice for your gram-positive, gram-negative, and anaerobes, but no role in atypical mycobacteria. Yeah, imipenem celastin is given as a combination because imipenem is very good drug. But the only problem with imipenem is it has higher seizure activity and is a very unstable drug. It gets destroyed very easily by the dihydropeptidase enzyme released by the kidney. Hence, it has to be given in combination with the celastin. And meropenem would be the most best drug, good drug, because it has low seizure activity, is a stable drug. That's the reason why most of the ICU prefer meropenem compared to all other carbapenems. The problem with doropenem is least seizure activity, but lower rate of resistance to Pseudomonas aeruginosa. And etrapenem, the biggest advantage of etrapenem over all the other drugs, because here in imipenem, meropenem, denopenem, you have to have 6th hourly or 8th hourly dosing of drugs, whereas etrapenem has only 1 a day dosing. Now, this would be a choice for doctors who want to shift the patients to from the ICU to, like, they want to get discharged, or they have any doctors in the family and all, can be given as drugs at home. Then etrapenem would be the group of drug in the carbapenems that can, because the advantage of etrapenem, it has only once a day dosing. So that was about your carbapenems. Monobactams you have, because it's mono and bactams. That means there's only one drug, and aztreonam is that one drug. Again, the activity of aztreonam against gram-positive, anaerobes, atypical, not a good choice. And yeah, again, gram-negative, it's a very good choice. Especially it can be given to patients who are allergic to penicillin and very active against and even it can given for any kind of sometimes UTI infections also, because it is not nephrotoxic compared to your aminoglycosides. Complicated UTI compared to amikacin, if you have no other drug in aminoglycosides group of drug, then aztreonam would be the next choice in pipeline. So next we have glycopeptides, the non-beta lactam drugs. They are very large molecules, active against only gram-positive bugs, poorly absorbed orally, hence it has to begin IV. So you have two drugs in this, vancomycin and teicoplanin. Vancomycin is definitely a very good drug against MRSA, highly active against Clostridium difficile also. As you can see, the drugs which were earlier we talked, most of the drugs can be given for most of the anaerobes except Clostridium difficile, because Clostridium difficile itself causes antibiotic associated diarrhea and forms pseudomembranous colitis. Hence, there are some special drugs that are given for that, and vancomycin would be the first drug of choice. And the only problem with vancomycin is you have hearing loss, you have Redman syndrome, then neutropenia. Teicoplanin, again, a very good drug, but it can lead to thrombocytopenia, and it is also a very good drug for MRSA. And both the drugs cannot be not a good choice for gram-negative anaerobes or atypical microbacteria. There's one more new drug that's not in the cell wall, this thing, but sorry, not in the beta-lactam ring, but it destroys the cell wall or bactericidal in action. That's the reason why I included phosphomycin. It's very active against the urinary tract pathogens, especially it could be gram-positive, gram-negative, and high MDR bug like Enterococcus faecalis or E. coli. Phosphomycin takes very good care, left out, especially in ICUs where untreated, complicated UTIs and all. This is one of the most drugs being used these days also, but the only problem is the cost. It's very costly. I mean, the bill will get piled up in a few days like this. And then you also have pacitresin, which is again a non-beta-lactam drug, which acts against very good against topical gram-positive infections like small injuries, wounds, abrasions, and all, or caused by gram-positive pathogen. It can be used topically. Then you have the drugs that acts on the cell membrane, the polymyxin group, which you have colistin and polymyxin B. Definitely a very good drug. Again, a uh, uh, reserve drug that is used for gram-negative bacteria. Positively charged causes cell lysis. The problem with colistin is nephrotoxic. As soon as possible, we try to have in mind that urge to withdraw it as soon as possible as the patient is recovering and de-escalate the drugs. And again, polymyxin B is a very active drug and relatively renal safe. Then you have one more good drug that is daptomycin, which is lipopeptide in nature. It acts very good against MRSA. Another, again, a reserved drug after your vancomycin for MRSA or your vancomycin resistant enterococci or penicillin resistant streptococci. But the side effects of daptomycin is causes reversible myopathy and never be given for any kind of lower respiratory tract infection, especially pneumonia. A very poor activity, daptomycin. Moving to the antibiotics that act on the protein, block the protein synthesis. Here you have your rifamycin. They are potent inducers of cytochrome B. Definitely, all this group of drugs are very good against Mycobacterium tuberculosis with their own side effects like orange distillation of tears, urine, or other body fluids. And in fact, rifabutin can be used as an alternative to rifampin in HIV patients. And there's another very good drug that rifaximin that is used for traveler's diarrhea. And also rifampicin is also used for carriers in meningococcal infection. So these are not much in typical bacteria, but for TB, it's the drug of choice. But another additional features as postgrads, you should remember that rifaximin is used for traveler's diarrhea. And the advantage of rifapentin is it has very good long half-life and once a week dose in TB, because TB drugs have to be taken and multiple drugs are there. Here, once a week dose in TB is a very friendly patient drug. Not a drug of choice for gram-negative anaerobes, atypical mycobacteria, and as I said, for gram-positive bacteria also, but very good drug for Mycobacterium tuberculosis. Coming to the aminoglycosides, yeah, they're positively charged, quite large molecule, then easily penetrate the gram-negative bugs. The very cautionary thing that the postgraduates and the interns should remember that the role of aminoglycosides in anaerobic conditions or anaerobic infection and also like abscess and all, it doesn't play in a role because aminoglycosides are oxygen dependent. So they do not play the very poorly in anaerobic conditions or acidic environment, and can be used in low doses with beta lactams for synergistic dose. As I said, you should not use two bactericidals or you should not use two bacteriostatic drugs. Drugs can be used. I mean, you can be used with beta lactam synergistic source. So it's the disadvantage of your aminoglycosides is the biggest disadvantage is it is nephrotoxic and ototoxic. The aminoglycosides. Otherwise, they are very wonderful drug. As you can see, streptomycin was the first drug, in fact, discovered for treating TB. Hence, the role of aminoglycosides in gram-positive is doubtful, but gram-negative, yes, you're good to go. But again, role of aminoglycosides in anaerobes, as I said, acidic environment and it's a not oxygen-free environment, and atypical, there's no role at all. And gentamicin can be used for both gram-positive and gram-negative infections. Amikacin can be, again, a reserved drug, and it can be used if resistant against gentamicin and tobramycin. But the problem with amikacin, there's less activity against enterococcus. See, these are all the learning things which the postgraduate should pick up or doctors working in your clinical microbiologist point of view. Now, each drug has its own importance, and you have to take a call where to apply this drug. So aminoglycosides are basically bactericidal in nature. As I said, their low doses can be used in low doses with beta lactams for synergies, because bactericidal drug cell wall also destroys the beta lactam does destroy the cell wall. The second part, that is the protein synthesis, that 30S ribosomal unit, is taken part by the aminoglycoside. So there will be synergistic action. So hence, never combine bactericidal drug with the bacteriostatic or vice versa. In fact, combine two bactericidal or two bacteriostatic is a carry message here. Coming to the macrolides, you have very good drugs over here. Again, uh, resistant to one macrolide group usually implies resistant to almost all the members. The only problem with the macrolides is thrombophlebitis and QT prolongation. So the patient would be having some kind of arrhythmias or restlessness, but they have to be told that these are the side effects of this drug, and it is an inhibitor of cytochrome P450 system, and they are complaints of blurred vision when you are on macrolides for a long stay. Now, what are the different macrolides we know? We have erythromycin, clarithromycin, azithromycin, telithromycin. Now, the role of macrolides in gram-positive, gram-negative is a bit doubtful. In anaerobes, doesn't play any role, but again, in atypical mycobacteria, again, kept as a doubtful case. Now, let's see why erythromycin usually less activity for respiratory infections as lack activity for hemophilian influenza. But azithromycin, as you can see, is sore throat. Most common drug used for your as a first line of treatment is azithromycin. Macrolides, in fact, cover atypical bacteria, but usually helps in treating upper respiratory tract infection rather than your lower respiratory tract. It takes care of the. That's the reason why sore throat is upper respiratory tract. Azithromycin takes care, taken up by the tissues and released over subsequent days. And erythromycin, atypical pneumonia, whereas a combination of piperacillin with teicoplanin and clarithromycin can also be used for deep, long-standing infections. So rather than giving individually, you should go for a combo of to show its effectivity. And also atypical bacteria like rickettsia, chlamydia, mycoplasma also can be taken care of with your drugs like tetracycline and glycycline. Now, compared to macrolides, tetracycline would be more taken as a choice. I'll tell you why. Here, not to no, the precautionary measures is not to be given to children and pregnant women because of the phototoxicity effect. Not a tetracycline is not a good choice for your gram-positive bacteria, except that latest one drug which has been added to the list, TG-cycline, which acts against, it's a very reserved drug, and what do you call, on permission it has to be sanctioned. It's not the first line or the second line. In fact, the last reserved drugs, depository drug, you can have it because it has a very good coverage against all gram-positive, gram-negative, anaerobe and atypical, very broad spectrum against MRSA, VRE, Acinetobacter. In fact, anaerobic activity less compared to piperacillin and carbapenems, and not active against Pseudomonas proteus. But otherwise, tigecycline is again a reserve drug. Now, minocycline, yes, for MRSA, it can also be given as drug, but the problem with minocycline is blue-black hyperpigmentation of skin and mucous membrane occurs. Doxycycline, again, a very good choice in case of atypical infections. These days, like we are not able to know out exactly what's the reason. It could be a bacterial, viral, fungal. So doctors are having this as second best line of drug, doxycycline, also for your STD infections because it has a long half-life and very effective. TG-cycline, again, as I said, is a very good drug, weak molecule, bacteriostatic in action. So, and it can be given for soft tissue infections and intra-abdominal infections also. It covers almost all gram-positive, gram-negative anaerobes, and also a part of atypical mycobacteria. Then you have chloramphenicol, which the biggest drawback is it causes bone marrow suppression. Not a good choice, but it can be given if you do not have any other drugs or empirically to start with for anaerobic or atypical drugs. Then you have your clindamycin, linezolid, and nitrofurantoin group of drugs. Clindamycin causes Clostridium difficile colitis, but active against community-acquired MRSA. Clindamycin can be given for MRSA cases, community-acquired. In case of road traffic accident where you have polymicrobial flora infections, you can also add clindamycin, which also gives an anaerobic coverage. Also with Staphylococcus aureus, it can cover. Not a good drug for gram-negative and atypical mycobacteria. Linezolid, is again a reserved drug for MRSA, and gram-negative intrinsically they are resistant to anaerobes and atypical, and complete synthetic drug should not be used with monoamine oxidase inhibitors because it causes serotonin syndrome and pancytopenia and metabolic acidosis. Again, this is a one more drug that has to be given a call to withdraw as immediately as the patient is recovering, or you find that the report has come with some lower order drug being susceptible. Nitrofurantoin, again, a very good drug, safe drug, most common favorite drug in for doctors, especially in for cystitis and accumulates in urine, UTI infections, it can be given. Clindamycin drug, again, as I said, aspiration pneumonia, superficial infections, covers gram-positive, also anaerobes, and uncomplicated UTI, you have nitrofurantoin. Coming to sulfur drugs, not much role in your ICU, but if you have patients with your dermatology, especially when they use it, or uncomplicated UTI, the cotrimoxazole being drug or dapsone, sulfur drugs is used for leprosy. Cotrimoxazole is a drug of choice, which is a combination of trimethoprim, sulfamethoxazole, or sulfadiazine. There's only side effects with sulfur drugs. You have to keep a watch on Steven-Johnson syndrome. Otherwise, it's not that good choice of drug for gram-positive, gram-negative, and not at all a choice for anaerobes or atypical mycobacteria. Coming to antibiotics that target DNA replication, we have quinolones. The problem with quinolones, it causes cartilage abnormalities and Achilles tendon rupture with a prolongation of QT interval. And you have here ciprofloxacin, levofloxacin, ofloxacin, gemifloxacin, and moxifloxacin. So ciprofloxacin more potent of quinolones against gram-negative bacteria. A very good choice for atypical and your gram-negative, the quinolones, including Pseudomonas aeruginosa, but weak against gram-positive. Cifran is drug for gram-negative bacteria, only atypical. Mostly it's used as a first-line empirically treatment, empirically drug of choice for in ICUs for gram-negative, including Pseudomonas we are suspecting. But levofloxacin, the advantage of levo over cipro is it covers both gram-positive and gram-negative ones, but doesn't less activity against Pseudomonas. Oflox, when you're comparing the side effects or the adverse effects, Oflox is a safe drug compared to levofloxacin. Again, you have to keep in mind there's a drug skin allergy. Most of the people come back with a rash on the skin with the drug. So the patient has to be told that this could lead to rashes on the skin, the fluoroquinolones especially. This has to be kept in mind, or history has to be asked in advance. Moxifloxacin and gemofloxacin more active against Streptococcus pneumoniae, including penicillin-resistant strain, and also a part activity against, partly small part of activity against gram against anaerobes. Atypical, if you're asking about atypical, then Cipro Livo would be good. Mycobacteria, atypical bacteria, because they are bactericidal compared to macrolides, which is bacteriostatic. So if there's a choice, because I have already told you atypical, you can take up macrolides. Atypical, now I'm telling you atypical can cover even fluoroquinolones. But ciprolevofloxacin would be the good choice empirically to start with compared to macrolides, because these drugs are bactericidal compared to bacteriostatic drugs, which are macrolides. And also Mycobacterium species coverage also would be there. Metronidazole, this is one of the drug which again attacks the topoisomerases 1 and 2. Good activity against gram negative, not a good choice for gram negative, gram positive. It's a very small drug and diffuse very fast. Drug of choice till today for any kind of anaerobic infections, or it could be even protozoal, anti-protozoal anaerobic infections, your trichomonas, your Giardia or Entamoeba histolytica. Metrozole would be the right drug. Yeah, as now we have covered the drugs which act for the different components of the cell wall. That is the cell, that is bacterial cell, your cytoplasmic membrane, then your protein synthesis, your nucleic acid synthesis, and your dihydrofolate, the folate synthesis. Now let's summarize things by looking at what exactly drugs are acting at which zone. Like you have gram positive bugs. Like what would be the empirically to start with, how to end it with the reserve drug. So you can start with, say, amino penicillin with your beta lactamase inhibitor. Don't start aminopenicillin or amoxicillin or some like this. You start with aminopenicillin because we are talking about ICU setup here. Penicillin with beta lactamase, or the next line of drug would be extended spectrum beta penicillin plus beta lactamase inhibitors. Then your third drug would be your carbapenems. And if it is gram positive exclusive, then you can start with linezolid. or you also have your glycopeptides, teicoplanin, and your daptomycin. Coming to the gram-negative bacteria, the first empirical drug that can be given is extended spectrum penicillin with beta-lactase inhibitors combination, or third, fourth generation cephalosporins. The only problem is again they can develop resistance very fast, and ceftriaxone or cefepime. Then you have the carbapenems, then the monobactams, then the reserve drugs would be your colistin and your quinolones. Atypical bacteria in ICUs, quinolones, as I said, would be the drug of choice. Then your tetracycline compared to your macrolides or tetracycline, because tetracycline has weak activity. Then move on to your anaerobes, aminopenicillin with beta-lactamase inhibitors, or extended spectrum penicillin with beta-lactamase inhibitors, or carbapenems. Or exclusively if you are targeting the anaerobes, then metronidazole would be the drug of choice compared to clindamycin, because clindamycin has weak activity for typical anaerobes. But if you are suspecting Staph aureus, especially community-acquired infection Staph aureus, then clindamycin can be added in combination with the carbapenems or your aminopenicillin beta-lactamase or extended spectrum penicillin with beta-lactase inhibitors. Culture susceptibility report and approach. Now, this is a very, very important challenging situation. Yes, you have either you will have the report, from the lab to the clinician. Now, if there is a presence of positive culture, right? Let me see here. Yeah. What three things can happen? Either you have a positive culture report, or you have a no culture or a pending report, or you have to start empirical antibiotics. Now, this is very challenging. If you have positive report, then it is easy to treat the patient because susceptibility tests are done. Easy also to know the pattern and choice. In others, like there is no positive culture report, pending reports, which is again very challenging. The doctor clinician is asking you, but you're not able to exactly come to any conclusion. You're going on doing your gram stain, your culture sensitivity, your Vitex, your MICs, or all that, but your unusual organism is going, you're not sure, you're doing bifair and all, you're still running helter-skelters. If there's no positive culture pending, or the result is mismatch, your results are not matching with the clinical condition, and in this case the patient needs to be managed empirically. Now this is where you get a call like, please tell us what antibiotic to start at least. So if you do susceptibility reports for certain organisms in your lab, there is no need to report all the, you also have to remember that. But then here you have to dig into your local antibiogram of your bugs in the hospital, and the drug susceptibility report to those bugs, 3 months data or 6 months data, what has happened, and you can then decide at that juncture what antibiotics can be given. There's another thing that you have to learn in your ICUs, and this is a very important challenging situation where you have to learn to communicate with your internist or your doctors. Is you do have such reports for certain organisms in your lab, but there is no need, as most of the senior faculty in our association also and all throughout the microbiology forum says, that there is no need to report all the ones you have done the test for. Okay, for example, if gram negative, if you can see this table, in gram negative pathogens, E. coli is susceptible. If to say if the generation the gram-negative organism is susceptible to third generation cephalosporins, beta-lactam for BLI, then you don't have to report higher drugs. Though you have the report, you have done testing, and it's with you in front of you. You don't have to report carbapenems, colistin, phosphomycin, keep them as reserve drugs, or you might be one of the reason to be the one of the cause for MDRs. Or if you have a pathogen like Staph aureus, it is susceptible to MSSA. You don't have to report vancomycin, teicoplanin, and tempt and urge the doctor to take up these drugs because it's very fancy and they have their own targets to be reached. Enterococcus, you have a sensitivity, suppository report to ampicillin or gentamicin, you don't have to report this. So you have to have this as hidden treasure with you, everything. So if patient is very critical, I'll tell you why. Because if patient is very critical and there is need to go on a broad spectrum antibiotic, then the results can be released on request. Otherwise, the reason is once you start on broad spectrum, de-escalating to narrow spectrum is very, very hard for you also to convince the internist or the clinician. So that's the reason why you don't have to reveal each and everything what you have on your report, the susceptibility result. Yeah, there are also some latest drugs which I found through a few of the articles and publication studies and trials that I would share with you. Like some have received FDA approval and some will soon, but most of these are not used for Indian scenario because they do look very fancy. Those terms are like ceftazolone, and it's very, I mean, this normal human nature that you come up with some new organism or new, I mean, bug or drug. It's like very tempting to talk about that, try to use or what, but please keep in mind that most of the drugs in Indian setup might not be fully fledged used, because Indian predominantly has metallo beta lactamase resistance, not all those bugs which are found in other countries. As you can see, like these are the combination ceftazolone with tazobactam, which is approved by FDA, but in India, no, except for Pseudomonas aeruginosa, again, Cetirizine avibactam, Meropenem vaborobactam, Astionum avibactam, Imipenem relibactam, Cefadicrol, plazomicin. So these are some drugs which have been approved from the FDA or in phase of clinical trial development, which are again against these genetic genotype markers active against, but in Indian setup, we still have to get the approval. Yeah, very, very important things. What is therapeutic efficacy? So basically, this is something like drug monitoring. And here I'm going to give you basically like our story doesn't end that we just release a susceptibility report with some drugs and antibiotics and all. It all not only relies in vitro susceptibility report result with MIC included. Our report or our strength of microbiology reporting not only relies on in vitro susceptibility result, but also dependent on a lot of other in vivo activities. It also like how this drug would act within the human body in turn, which all is a call for PK/PD parameters of the antimicrobial agent. That's the reason why you also have to have a what do you call a pharmacist or a very knowledgeable person in your committee, antimicrobial stewardship, who can give a good judgment on these values to be calculated and give the right dose to the clinician. And it's very necessary to find out how the drug behaves in vivo. Important for antibiotics, especially like vancomycin and your amikacin and cholesterol, because there's a dosing that has to be done. And especially when vancomycin MIC is more than 1 microgram per ml, then it's avoided usually. Then also MIC helps to select the most appropriate antibiotic, which is a golden statement. Everybody agrees with that. And we also know that day in, day out, we hear that lower MIC, better therapeutic efficacy. And if there is more than one antimicrobial agent showing susceptible, antibiotic having lowest MIC when compared to susceptibility break point chosen for that one. If you have more than one antimicrobial susceptible, here what we do, we choose the drug which has lowest MIC for therapy. So this is again a golden thing, and everybody knows this is a general statement. But I would suggest that better guided by calculating the therapeutic index, which is just an add-on point to your MIC values. Now, what is this therapeutic index, which is also called breakpoint coefficient? Therapeutic index is a value which you get by dividing susceptibility breakpoint with MIC of the test isolate. Now, where do you get this susceptibility breakpoint? You get by the on the website. It's very available on the UCAST and the CSA guidelines. So, higher the therapeutic index, better is the efficacy of antimicrobial agent. Okay, what we had earlier, we thought lower MIC, better drug, but here it's a something new add-on point that higher the therapeutic index, better the efficacy of the antimicrobial drug. So, how do you get it? Let me give you an example. For example, in a clinical isolate of E. coli, which is known to susceptible to both meropenem, whose MIC is 1 micrograms per ml, and amikacin, whose MIC is 8 micrograms per ml. Then looking at this, definitely, okay, you have two drugs and its MIC value is low. It would, meropenem would definitely be a choice and showing more efficacy. But here, however, the MIC value compared with the standard susceptibility breakpoint and not the absolute MIC value determines the therapeutic efficacy. So what we have to learn here is you have to add on more. Like susceptibility breakpoints of meropenem, amikacin are 1 and 16 respectively, according to CLSA guidelines 2020. Okay, so now you have the breakpoints value, you have the MSC values. What you have to do, you have to divide them. Then you get the therapeutic index and the which is your breakpoints divided by your breakpoint divided by your MSC value. Okay, then you get, see, the therapeutic index of meropenem here is 1, the amikacin is 2. Now the entire scenario changes here. What earlier we said, meropenem MSC value is less, so meropenem would be the drug of choice. But here, when we do the exact the drug dosing and the therapeutic point analysis, here what we are finding is the therapeutic index of amikacin is more compared to meropenem, and we state the statement that more therapeutic index, more the efficacy would be the drug. Now the entire scenario is changed. Amikacin would be the drug of choice is superior to meropenem. So finally, with that few important critical decisions to be take, I think you have to teach early and very often. We have to be on the education, attending seminars, webinars, or whatever it, because our knowledge is something like half-life of a drug. So hence we have to keep updating ourselves. Yeah, that would end my session. I would definitely try to take some questions or queries if anybody, any postgraduates or any junior faculty has. I think there are some questions in the chat. Yeah.
Thank you so much, sir. On behalf of IAMM-TAPC, I sincerely thank Khalil sir for having this wonderful session. Sir, your expertise and passion have given us a lot to learn, sir.
Thank you, Vijay.
Yet again. We've had a good attendance, almost like 100 plus
Oh,
throughout the
seriously, that's
session.
really great. Yeah, nice, nice, good.
We open up for questions now for about 5 minutes. Please do type in your doubts or questions in the chat box. One
Or if
question
you,
One question that has come in is treatment of choice for MDRO. I would take it to be carbapenem resistant organism.
yes, yes.
Probably if you can answer that, sir. Current choice of antibiotics for carbapenem resistant gram negative.
Yeah, you have a common, then you have carbapenem resistant, you have this ceftazidime avibactam with uh, meropenem.
No, with astrinum, I guess, sir.
With astrinum, yeah. You can have a combination of that. Just a minute, I'll just check out my diary also.
From our experience, what we've seen is like for enterobacterials, ceftazidime avibactam plus astrinum still does a good
Astrinum,
job.
okay.
Yeah, it does a good job, but then again, you need to prove the synergy. Once the synergy testing is done and then it is proven to be synergistic, that combination can be used for enterobacterials.
Enterobacterials, yes, yes, Vijay.
With regard to other non-enterobacterials, or if you're talking about non-fermenters like Acinetobacter, then when we're talking about crab, carbapenem resistant Acinetobacter, then it can be meropenem plus colistin plus TG cycline. And then IDSA actually recommends that high-dose sulbactam should be added in. So people are now trying colistin plus TG cycline plus a high-dose antisulbactam or cefoperazone sulbactam.
Yeah, but these are all reserved drugs, and I mean, you have to take
Yeah,
a
yeah, we are talking about
empirically. I mean, yeah, exactly.
not empirical. I mean, like they are talking. The question was about resistant bugs. So
Resistant organism bugs in the ICU. Yes.
one question, sir: role of microbiologist in preventing a patient landing into sepsis who came with a localized infective focus.
How do you prevent a patient landing in?
Into sepsis, somebody who came in with a local infection, how do you prevent them from landing into sepsis?
Basically, you have to have this all the precautionary measures, because coming with some problem and landing in sepsis in ICU is when taking care of all those precautionary measures, hand hygienes, and what do you call stringent measures of uh, cross prevent the cross infections. And what exactly would be the infection is what we have to know. I mean, the suspected report, and if you what exactly is the question? I didn't understand. I mean,
Basically, I think if we treat or hit hard the like
hit
local,
early, hit hard would be the most right drugs.
I'm like the right antibiotic for
Yeah,
that local.
like you are right antibiotic, like you say, combination of with beta BLI drugs would be to start with, would be good to start. Again, better to have the report with you and check out the suspicious pattern.
Yes.
There's one question. Is it okay I answer, because I got it on
Yeah,
my
yeah.
WhatsApp?
Please, please.
Yeah. What is the role of antibiotic cycling or intravenous to oral shifting de-escalation in ICUs?
Yeah, please.
Yeah, because see here, evidence of benefit of antibiotic cycling is as such lacking, which was prior done with few studies demonstrating a reduction of correlation through mortality and length of stay, hospital stay remains unknown. So therefore, antibiotic cycling should never be used as a method of antibiotic stewardship program. I mean, in fact, rather than that, we should have regular audits and feedback to improve our adherence, what I feel like. And strategies like de-escalation and timely transition from IV to oral therapy are required at the same time. As I said in my talk, that you should be ready to take a call from shifting the patient from IV to oral therapy is one more thing. And also, while choosing antibiotics, what precautions to be taken? This is another very important question. Like there are a lot of other factors, not like just prescribing or giving the report. There are like renal and renal functions, which organ the antibiotic is being targeted. For example, if you are talking about polymyxin B, which is very less nephrotoxic, and that can be used in complicated UTI infections, it won't act. And at the same time, tigecycline is a very good drug, but doesn't penetrate the lungs, hence cannot be used for respiration. So there are a lot of what do you call factors. I mean, like daptomycin should not be given in lung infection, or antibiotics such as chloramphenicol, macrolide should be avoided in UTI. Loading dose, infusion drugs like vancomycin especially act when they are infused and given. So these things also have to be renal adjustment. The parameters of renal and liver have to be taken into consideration. One more question, sir. What is the difference between sparing antibiotic and salvage therapy? Okay. Let me answer this question. Let me answer. You take an example. Like, see, we have ceftazidime avibactam plus, which is used as a carbapenem sparing molecule. So sparing molecules, basically you keep them as reserve. I mean, we know that organism is sensitive to both antibiotics like ceftazidime and avibactam. So to prevent resistant or slow down, we reserved it. But salvage therapy is, we know that organism is resistant to that particular antibiotic, and we are using empirically, then or can change to salvage therapy for that particular organism. So after studies and trials have done, various studies have gone through the publication. Initially, ceftazidime avibactam was used as salvage therapy in ICUs, but these days it has been used as carbapenem sparing molecule. As you said, that's one of the first question what is asked, right? Which drug should be given in that? So ceftazidime avibactam was used as a salvage therapy, but now it is being used as a sparing molecule. Role of procalcitonin as a marker for sepsis in ICU. Procalcitonin, see, I mean, normally this is a misnomer that it is a good marker of sepsis in ICUs and all, but it is only a marker for gram-negative sepsis, not for gram-positive or fungal or TB. This first thing you have to keep in mind, and it's usually raised in gram-negative septicemia, and the level helps in de-escalation of antibiotics during treatment in ICU. It will give us to take a call to just reduce the antibiotics in ICU. So that is what is the role of procalcitonin in ICU, what I think is.
Thank you, sir. There's one question with regard to colonizers and pathogens, and another question about cons. I would like to answer that, sir.
Yeah, please, please.
So with regard to colonizer and pathogens, if you're doing a single blood culture with one bottle, then it's very difficult to differentiate whether you're picking up a colonizer or a pathogen. It's always recommended that you do minimum 2 sets, optimally 3 sets, and then each set containing at least 2 bottles, and collect it from different sites. So what happens is, like, when you have the same organism growing from multiple sites or the bottles, then you're sure shot that, okay,
Pathogen.
this is the pathogen and not a skin colonizer that you've picked up. This is the only way to prove it. Otherwise, with a single blood culture, which is normally sent, it's very difficult to differentiate. Sometimes what happens is, like, in our ICUs, we do get what do you call, not rather ICUs, even in wards, you do get carbapenem resistant Acinetobacter baumannii, or in ICUs, you get carbapenem resistant Acinetobacter baumannii. Whereas when you call the consultant up, and then they say that the patient is doing very fine, doesn't correlate with the bug that has been isolated. So that shows that possibly the ICU is colonized, and yes, the patient has got colonized the skin, and then there was no proper antisepsis done while drawing the blood collection, and then the same comes in. Whereas if you would have collected multiple blood cultures, that would have helped you answer that.
So that means to say one isolation, one bug, though it looks like a pathogen, but you cannot define it as a pathogen. Hence, it has to be collected from multiple sites, multiple bottles, and you isolate the same organism in different blood culture, different sites would be a pathogen, right?
Yes, sir.
Yes.
Same applies to cons.
Yes, yes, definitely. Okay, shall we call it a day, Vijendra?
Right, done. Thank you so much, sir. Thank you for your time, and thank you all the attendees. We look forward to meet you again in the upcoming session. Until then, thank you. Have a wonderful evening. Thank you, sir.
Thank you. Thank you, Vijendra. Goodbye.